More than 40% of older adults take 5 or more prescription medications, but that number is not the part that should frighten you. The frightening part is how often memory loss gets blamed on aging when the real problem may be sitting in the medicine cabinet. Not one dramatic pill, not one obvious poison. Ordinary medications, allergy pills, sleep aids, anxiety pills, bladder pills, pain pills, muscle relaxers. Medicines taken exactly the way the label says, sometimes for months, sometimes for years. While the family slowly watches a sharp mind become slower, foggier, quieter, and easier to confuse. This is where families make the mistake. A forgotten appointment becomes old age. A misplaced wallet becomes normal forgetfulness. A senior repeating the same question becomes dementia. A person sleeping through the afternoon becomes slowing down. But after 30 years caring for older adults, I can tell you something your doctor may not have had time to explain this bluntly. Sometimes the brain is not failing first. Sometimes the medication list is burying it. And if nobody reviews that list, a treatable drug effect can be mistaken for permanent decline. That is the danger, not just memory loss, misnamed memory loss. Memory loss that gets accepted too early. Memory loss that makes a family start planning for dementia when the first step should have been opening every bottle on the bathroom shelf and asking one hard question: could this be coming from the medicine? I'm Dr. William Hayes, and today I want to walk you through 8 common types of medications that can make memory, focus, alertness, and thinking worse in older adults. This is not a stop your medication video. That would be dangerous. Some of these drugs may be necessary. Some should never be stopped suddenly. This is a medication review video. Because after 65, the brain handles medicine differently. The liver may process drugs more slowly. The kidneys may clear them less efficiently. The brain becomes more sensitive to sedation. The barrier protecting the brain can become more vulnerable. A dose that seemed harmless at 45 can feel like a mental fog at 75. And the most dangerous part is that the change may not look like a side effect. It may look like aging. Number 8, over-the-counter allergy pills and PM sleep aids that contain diphenhydramine or doxylamine. These are some of the most underestimated brain fog medications in the homes of older adults because they do not feel serious. They are sold next to cough drops, pain relievers, and vitamins. They are packaged as allergy relief, nighttime cold medicine, or simple sleep help that makes them feel safe. But safe-looking does not mean gentle on the aging brain. Diphenhydramine and doxylamine have strong anticholinergic effects. That means they block acetylcholine, a chemical your brain uses for memory, attention, learning, and alertness. When acetylcholine is blocked, the brain can feel slower. Names become harder to retrieve. Conversations become harder to follow. Morning confusion becomes easier. Balance can worsen. Dry mouth, constipation, blurry vision, and urinary trouble can appear. But the brain effects are the ones families often miss. The danger is not one restless night. The danger is turning a nighttime pill into a nightly habit and then calling the next morning's fog normal aging. A senior takes a PM product to sleep. The next day, the brain feels heavy. The family notices slower thinking. The senior becomes less steady. Another dose is taken that night because sleep was still poor. Over time, the pattern becomes invisible. The pill is seen as help, while the fog is blamed on age. That is how a medicine can hide in plain sight. If an older adult is taking an allergy pill that causes drowsiness, or any sleep product with diphenhydramine or doxylamine, it deserves a medication review. The question is not whether the pill works. Many of these pills do make people sleepy. The question is what price the brain pays for that sleep. Number 7, benzodiazepines for anxiety or sleep, including alprazolam, lorazepam, diazepam, clonazepam, and similar drugs. These medications can be useful in selected situations, but they are among the drugs I worry about most when they quietly become long-term habits in older adults. Benzodiazepines slow brain activity. That is part of why they calm anxiety and help with sleep. But a brain that is slowed too much does not only feel calmer, it can become less sharp. Reaction time slows. New memories may not form as well. Balance worsens. Daytime alertness drops. The person may look peaceful, but the brain may be operating under sedation. This is where the harm can be misread. A senior becomes less engaged. Conversations become shorter. Appointments are forgotten. The afternoon disappears into sleep. The family begins to see decline. But the decline may not be only the disease of aging. It may be chemical slowing. The danger becomes greater when benzodiazepines are combined with alcohol, opioids, sleep medicines, or other drugs that depress the central nervous system. The brain can become too quiet. Breathing can slow. Falls become more likely. Confusion can deepen. And with benzodiazepines, there is another critical warning. They should not be stopped suddenly after regular use. Abrupt stopping can cause dangerous withdrawal, including seizures in some cases. So the answer is not panic. The answer is not throwing the bottle away. The answer is a careful, supervised conversation with the prescribing clinician. The question to ask is simple and powerful. Does this medicine still need to be here at this dose, at this age, with this memory problem? Number 6, Z-drug sleeping pills, including zolpidem, ezopiclone, and zaleplon. These drugs are often presented as different from benzodiazepines, and chemically, they are different. But in an older brain, the outcome can look disturbingly similar. Sedation, confusion, falls, memory gaps, and strange nighttime behavior. This is the sign families miss. The person may not remember getting up, they may not remember a conversation, they may feel heavy in the morning, they may look awake, but not fully connected. Sleep medication can create the appearance of rest while quietly damaging the next day's clarity. After 65, sleep is already lighter and more fragmented for many people. Adding a sedating hypnotic can turn sleep into a trade. The person may fall asleep faster, but morning function may suffer. A clear morning can become a foggy morning. A steady walk to the bathroom can become a fall risk. A normal conversation over breakfast can become slow, confused, or repetitive. The danger is not only the pill at bedtime. The danger is what happens at 3 in the morning and 8 the next morning. A fall on the way to the bathroom, a stove left on, a medication dose taken twice, a morning drive made with a brain that is not fully awake. If a senior is using a sleeping pill regularly and memory is getting worse, the sleep medication must be part of the conversation. Not because sleep does not matter. Sleep matters deeply. But drugged sleep and restorative sleep are not always the same thing. Number 5, bladder control medications, especially anticholinergic drugs such as oxybutynin, tolterodine, sulfasenacin, and similar medicines. This category surprises many families because the drug is not prescribed for the brain. It is prescribed for urgency, frequency, leakage, and overactive bladder. The problem is that the bladder and the brain can be affected by the same chemical blockade. Many bladder medications work by calming bladder contractions through anticholinergic action. But acetylcholine is not only involved in bladder signaling. In the brain, it is deeply involved in memory and attention. When the medicine blocks that signal, the bladder may calm down, but the brain may become slower. This is the trade-off families often never hear clearly. Fewer trips to the bathroom can come with more confusion. Less urgency can come with more forgetfulness. A drier night can come with a foggier morning. That does not mean every bladder medication is wrong. It means the brain cost must be considered, especially in someone already showing memory problems. The dangerous pattern is quiet. A senior starts a bladder pill. Weeks later, short-term memory looks worse. The family separates the two events. The bladder problem is medical. The memory problem is aging. That separation can delay the truth. If memory worsens after a bladder medication is started or increased, that timing matters. If dry mouth, constipation, blurry vision, sleepiness, or confusion appear with it, that pattern matters even more. The bladder may be quieter because the nervous system is being quieted, and in an older adult, a quieter nervous system can mean a more vulnerable brain. Number 4, older antidepressants and strongly anticholinergic mood medications, including amitriptyline matcha, nortriptyline matcha, imipramine, doxepin at higher doses, and paroxetine. These medicines may be used for depression, anxiety, sleep, nerve pain, headaches, or other conditions. Some can be very effective in the right person. But after 65, certain antidepressants can carry a heavier cognitive burden than families realize. The issue again is anticholinergic effect, sedation, blood pressure changes, and the way these drugs can accumulate or interact with other medications. Memory does not always fail dramatically. It can become less reliable. Attention becomes thinner. Processing speed drops. A person may begin to feel mentally coated, as if a layer has been placed between them and the world. The danger is that depression itself can also affect memory. Pain can affect memory. Poor sleep can affect memory. So when an older adult taking one of these medicines becomes foggier, it is easy to blame the original condition instead of the medication. That is why timing matters. Did the memory change begin after the dose increased? Did the confusion worsen after a new medication was added? Did falls, dizziness, constipation, dry mouth, or daytime sleepiness appear at the same time? These details are not small. They are clues. The frightening outcome is not just forgetting a name. It is losing confidence, withdrawing from life, stopping activities, and being labeled as declining when the brain may be reacting to a medication load that is too heavy. A medication meant to help mood or pain should not quietly take away alertness, independence, or the ability to think clearly without being questioned. Number 3, opioid pain medicines including hydrocodone, oxycodone, morphine, codeine, and sometimes tramadol. Pain can destroy quality of life, and pain control matters. But opioids can also slow the brain, especially in older adults. They can cause sedation, confusion, dizziness, constipation, slowed breathing, and delirium. The danger increases when opioids are combined with benzodiazepines, sleep medicines, alcohol, muscle relaxers, or other sedating drugs. This is where the medicine cabinet can become dangerous as a system, not because of one pill alone, but because of the combined effect. A pain pill after surgery, a sleep pill at night, an anxiety pill left over from years ago, a muscle relaxer for back spasms, each one may have a reason. Together, they can turn the brain into a dimmed room. Memory becomes unreliable. Balance weakens. Reaction time slows. The person becomes easier to confuse and harder to wake fully. The family may see this as sudden dementia, but it may be medication-induced delirium or drug accumulation. Tramadol deserves special respect because many people think of it as a lighter pain medicine. But in older adults, it can still affect alertness, increase fall risk, interact with antidepressants, and contribute to confusion. The danger is not only addiction, the danger is cognitive dulling, falls, constipation, dehydration, and a cascade that can send an older adult from independent living to the hospital. If memory worsens after a pain medicine is started, increased, or combined with other sedating medication, do not dismiss it. Pain treatment should relieve suffering, not quietly erase the person behind the pain. Number 2, muscle relaxers and certain dizziness or nausea medicines, including cyclobenzaprine, carisoprodol, methocarbamol, meclizine, promethazine, and similar sedating drugs. These medications are often used for back spasms, neck pain, vertigo, nausea, or motion sickness. They can feel practical and temporary, but in older adults, temporary pills can create very real brain fog. Many of these medications are sedating. Some have anticholinergic effects. They can slow reaction time, worsen balance, cloud memory, and increase fall risk. A senior takes a muscle relaxer for a stiff back. The back may feel calmer, but the brain may become slower. A dizziness pill may reduce the spinning sensation, but it may also make the person sleepier, less steady, and less mentally sharp. The problem is that these drugs often enter the home during a short-term problem and then remain available for repeated use. A pill for a bad back becomes a pill for any discomfort. A dizziness pill becomes something taken whenever the head feels strange. Over time, the family forgets it is there. The brain does not. The danger is not only memory loss, it is the combination of fog plus imbalance. That combination can be devastating after 65. A foggy brain forgets the cane. A sedated body misses the step. A slowed reaction turns a stumble into a fracture. A fracture turns into hospitalization. Hospitalization turns into delirium. Delirium turns into a decline that may not fully reverse. That chain can begin with a pill that looked harmless. If a senior becomes more forgetful, sleepy, unsteady, or confused after using muscle relaxers or sedating vertigo medicines, that is not something to normalize. It is a reason to review the medication. Number 1, the medication stack. This is the one I fear most because it is not one drug. It is the combination. One anticholinergic allergy pill, one bladder pill, one sleep pill, one pain pill, one anxiety pill, one muscle relaxer. Each medication has a purpose. Each one can be defended. Each one may have been started by a different clinician at a different time for a different problem, but the aging brain does not experience them separately. The aging brain experiences the total burden. This is where families get trapped. The memory loss does not begin the day one bottle is opened. It creeps in after the stack grows. Morning fog becomes normal. Afternoon sleep becomes normal. Repeating questions becomes normal. Unsteady walking becomes normal. Confusion after dinner becomes normal. And then the family begins to use the word dementia before anyone has counted the sedating and anticholinergic load sitting in the cabinet. The most dangerous phrase in this situation is everything on this list was prescribed. Prescribed does not always mean still appropriate. Prescribed 5 years ago does not mean ideal today. Prescribed before kidney function changed, before a fall, before memory loss, before a new sleeping pill, before a new bladder drug, before a pain medication does not mean the combination is still safe. Medication lists age just like bodies do. They need review, they need pruning, they need questions. The brain may not need another memory supplement. It may need fewer brain-slowing drugs. The family may not need to accept rapid decline as inevitable. It may need a pharmacist and physician to examine every prescription, every over-the-counter product, every PM sleep aid, every dizziness pill, every bladder pill, every old bottle kept for just in case. This is not about blaming medicine. Medicine saves lives. Blood pressure pills prevent strokes. Diabetes medications protect organs. Antibiotics treat infections. Pain medicine can restore function. Psychiatric medications can be necessary and life-changing. The danger is not medicine itself. The danger is an aging brain carrying a medication burden nobody has stepped back to see as a whole. So bring the 8 categories together. Number 8, over-the-counter allergy pills and PM sleep aids with diphenhydramine or doxylamine. Number 7, benzodiazepines such as alprazolam, lorazepam, diazepam, and clonazepam. Number 6, Z-drug sleeping pills such as zolpidem, esopiclone, and zaleplon. Number 5, bladder control medications with anticholinergic effects, including oxybutynin and similar drugs. Number 4, older antidepressants and strongly anticholinergic mood or pain medications such as amitriptyline, nortriptyline, imipramine, doxepin at higher doses, and paroxetine. Number 3, opioid pain medicines, including hydrocodone, oxycodone, morphine, codeine, and tramadol. Number 2, muscle relaxers and sedating dizziness or nausea medicines, such as cyclobenzaprine, carisoprodol, methocarbamol, meclizine, and promethazine. Number 1, the medication stack, the combined burden of several brain-slowing medicines taken together. If you or someone you love is taking one of these medications, do not stop it suddenly. That is especially important with benzodiazepines, opioids, antidepressants, seizure medicines, and psychiatric medications. Stopping abruptly can be dangerous. The right move is a medication review. Bring every bottle. Prescription medications, over-the-counter medications, sleep aids, allergy pills, pain pills, bladder pills, supplements, old bottles used occasionally. Do not rely on memory. Put them in a bag and bring them to the appointment or review them with a pharmacist. Then ask clear questions. Which of these can affect memory? Which can cause confusion? Which can increase falls? Which are anticholinergic? Which are sedating? Which are still necessary? Which dose is still appropriate for this age and kidney function? Which medications are interacting with each other? The goal is not to remove everything. The goal is to remove what no longer belongs and reduce what may be harming the brain. If memory has been getting worse, track the timeline. When did the forgetfulness begin? What medication was started before that? What dose changed? What over-the-counter sleep aid was added? Did confusion worsen after a hospital visit, a fall, a surgery, or a new pain prescription? Specific timelines change the conversation. Vague fear gets dismissed. Clear patterns get investigated. And if confusion appears suddenly, if a senior becomes severely disoriented, extremely sleepy, difficult to wake, hallucinating, falling repeatedly, having trouble breathing, or acting dramatically different from normal, that is not a routine memory complaint. That needs urgent medical attention. The brain can be injured by delay, but it can also be rescued by asking the right question early enough. The question is not only whether this is dementia, the question is whether the medication list is making the brain look worse than it truly is. If this made you think of your own medicine cabinet, type 8 in the comments. Tell me which category surprised you most. The allergy pills, the anxiety pills, the sleeping pills, the bladder pills, the antidepressants, the pain pills, the muscle relaxers, or the medication stack. And if someone in your life is becoming more forgetful while taking multiple medications, send them this video, not to scare them, to give them a question that might change everything. I'm Dr. William Hayes. I have spent 30 years watching families assume the brain was simply fading, when the first step should have been reviewing the bottles. Sometimes memory loss is disease, sometimes it is aging, but sometimes it is a warning written in the medication list. In the next video, I'm going to show you 5 common sleep habits after 65 that can make memory worse by morning, including one habit many seniors do because they think it protects their brain. Watch that next, because the medicine cabinet is only one place memory can be stolen. The bedroom is another. Take care of your brain. Take care of each other. And remember, the pill that helps one symptom should never be allowed to quietly steal the person behind it.